All right, let's get straight into it. This is your rapid-fire, high-yield review of infective endocarditis, built specifically for the busy Aussie ED clinician. We're going to skip all the fluff and just hit the key stuff you absolutely need to know for your next shift.
Okay, let's jump right in with a classic. You've got a patient in front of you, they've got a fever, and when you listen to their chest, you hear a new murmur. So what's shooting to the top of your differential? It's got to be infective endocarditis, right? This is one of those presentations you just cannot afford to miss. So here's our game plan. We'll quickly cover what IE actually is, who gets it and why, what they look like when they present, how to lock in the diagnosis, and finally, what you're actually going to do about it in the ED. Let's do it. Right, first things first. Let's get our heads around the pathophysiology. What is actually happening inside the heart? Because if you get this, all the complications that follow make a whole lot more sense. So what are we really talking about here? At its core, it's an infection of the endocardium. That's the inner lining of the heart. It usually loves to hit the heart valves. And the real danger? It forms these nasty little infected clumps called vegetations, which can break off, fly anywhere in the body, and cause absolute chaos.
It's really a four-step process, kind of a perfect storm. First, you get a little bit of damage to the heart lining, maybe from turbulent blood flow around a dodgy valve. Second, the body tries to patch it up with a sterile clot. Third, some bacteria get into the bloodstream, maybe after a dental procedure or something. These bugs find that nice sticky clot, and boom, step 4. They set up shop, multiply, and build this big infected mass we call a vegetation. And that's your ticking time bomb.
Okay, so now that we know how it happens, let's talk about who gets it and what causes it. This is super important because it really helps you tailor your thinking and your treatment from the get-go. Look, about 80% of the time, it's going to be one of these 3 usual suspects: staph, strep, or enterococcus. But here's the kicker. The real clinical pearl isn't just knowing their names. It's about predicting which one is most likely based on the person sitting right in front of you. And this table is pure gold. Seriously, you see an intravenous drug user, your brain should be screaming, Staph aureus tricuspid valve. Got a patient with a brand new prosthetic valve, less than 2 months old? Think staph epidermidis. An older patient who just had a bowel or urinary procedure. Enterococcus should be right at the top of your list. Nailing these associations is key, both on the floor and in your exams. So this is your mental checklist when you're taking a history. Is there any prosthetic material in the heart? Have they had IE before? That's a massive red flag. Are they an IV drug user? What about their teeth? Don't forget to ask about recent dental work or just general poor oral hygiene. It's a classic gateway for these bugs to get in. All right, let's move to the bedside. What does this patient actually look like when they roll into your ED? What are the signs and symptoms you're really hunting for? Well, number 1, with a bullet, is fever. A whopping 90% of patients are going to have one. But a word of caution, don't get caught out. In your elderly patients or someone who's immunocompromised, it might be a bit more subtle, a bit low grade, so you have to be looking for it. And here it is, the absolute money sign, a new or changing murmur. Seriously, if you remember nothing else from this, remember this. A meticulous cardiac exam is non-negotiable. A fever plus a new regurgitant murmur, well, in my book, that's infective endocarditis, until you prove it isn't. Okay, classic exam question alert. You have to know the difference between Osler's nodes and Janaway lesions. Here's the easy way to remember it. Osler's nodes are ouchy. They're tender, raised, and on the pads of fingers and toes. They're an immune thing. Janaway lesions? They're painless spots on the palms and soles, and they're embolic. Just remember, O for Osler, O for ouch. All right, so your spidey senses are tingling. You have a strong suspicion for IE. How do you actually formalize that? Well, you don't just guess. You use the modified Duke criteria. This is the diagnostic standard. Think of it like building a case in court. You've got your major criteria. These are the slam dunks. Definitive proof. So that's positive blood cultures with the right kind of bug, or actually seeing something on an echo, like a vegetation or an abscess. Then you've got your minor criteria. This is all your supporting evidence. The predisposing conditions, the fever, and those embolic and immune signs we just talked about. And here's the formula you just gotta know. To get a definite diagnosis, you need either 2 major criteria, simple, or 1 major plus 3 minor. Or if you've got no majors, you can still get there with 5 minor criteria. That's it. 2 majors, 1 and 3, or 5 minors. Lock that combination in.
Right, you've nailed the diagnosis. Now what? The clock is officially ticking. Let's talk about your immediate action plan in the ED and the big, scary complications you need to be watching out for.
Okay, let's get this straight. Before a single drop of antibiotics goes into the patient, you need blood cultures. And not just one set. Get 3, maybe even 4 from different sites if they're stable enough. Got 'em? Good. Now you can start antibiotics based on the Aussie guidelines. For native valve, it's typically your benzylpenicillin, gent, and Fluclox. For a prosthetic valve, you're going to swap out that benzylpenicillin for vancomycin to cover the tougher bugs. And this is why we take IE so seriously. The #1 killer here isn't septic shock, it's heart failure. The infection literally chews through the valve until it fails. You also have to be on high alert for embolic stroke, which happens in up to 20% of patients. And another big one, if you suddenly see a new heart block on the ECG, you have to worry about an abscess burrowing into the heart's conduction system.
And this quote really just says it all, doesn't it? Delay is deadly. Our job in the emergency department is to be fast. We've got to spot it, culture it, treat it with the right drugs, and get our colleagues involved early. Cardiology, infectious diseases, and especially cardiothoracics if things are going south.
Okay, let's hammer home the key takeaways, the stuff you absolutely have to remember. IVDU, think Staph aureus and the tricuspid valve. Always get 3 to 4 sets of blood cultures before antibiotics. That new murmur is your single most important sign. Heart failure is the biggest killer. Osler's nodes are tender, and no one to pick up the phone and call the surgeons. Heart failure, an abscess, or if they keep throwing clots.
And that's a wrap on our high-speed tour of infective endocarditis. I really hope you found that useful. If you did, and you want more of this kind of practical, high-yield content for emergency medicine, do us a favor and hit that subscribe button. Cheers, and see you for the next one.